Good morning everyone. Today we are going to talk about hip dislocation. And before going to the hip dislocation, let's first know about some bones of hip. So, this is the pelvic girdle. This is the pelvic girdle and this pelvic girdle is made up of different bones and this is ilium, this is iliac crest, this is iliac spine and this is acetabulum which makes the hip joint. In this acetabulum, the head of the femur fits and makes the hip joint and this is ischium and this is pubis. So, this is the normal anatomy of hip bones. Now talking about the hip dislocation. Now let's see this figure. In this figure, there is a presence of this acetabular socket. We can see this acetabulum socket where the head of this femur bone is lodged. And hip dislocation literal meaning is the dislocation or displacement of this head of the femur in different directions. And if there is displacement of this head of this femur anterior to this acetabulum socket, then it is known as anterior dislocation. Whereas if the direction of the displacement of the head of the femur is behind or posterior to the acetabulum, then it is known as posterior dislocation. And if this head of the femur goes towards the center, towards the pelvis, this is pelvis, goes towards the pelvis by piercing this acetabular wall, then this is known as center dislocation. So there are three types of hip dislocations and they are anterior, posterior and center dislocations. As we have already discussed, there are three main types of dislocations of hip according to the direction of femoral head displacement, and they are anterior, posterior and central. The posterior one is the most commonest one, and in this type, the head of the femur is pushed out of acetabulum posteriorly, and 50% of this dislocation is associated with a chip fracture of a posterior lip of acetabulum, which is also known as fracture dislocations. And the anterior one is the rear one, in which the head of the femur is pushed out of acetabulum anteriorly. And now talking about the central one. In central dislocation, the femoral head is driven through medial wall of acetabulum towards the pelvic cavity, and this is the most rare type, and it is seen in patients with metabolic disorders. And the head, in this type, the head is palpated on per rectal examination as well. Now talking about the etiology. Let's talk about the mechanism of injury of posterior hip dislocation, as it is the most common one. So, the mechanism of injury of posterior hip dislocation. The injury is sustained by violence directed along the shaft of femur with hip flexed, and it is most commonly seen in motor accidents, and the typical injury is also known as dashboard injury. In this injury, the occupant of the car is thrown forward and his knees strikes against the dashboard. So the force is transmitted. Okay, so the force is transmitted of the femoral shaft and resulting into the posterior dislocation of the hip. So this is also known as dashboard injury. And now talking about the etiology of anterior dislocations, it mostly occurs when the legs are forcibly abducted and externally rotated. It is most commonly seen in the cases such as fall from the tree and RTA, that is road traffic accident. In this case, there is true lengthening of the legs and the head is palpable at the groin. Now talking about the clinical features of posterior dislocation, first of all there will be history of trauma, which is followed by pain and swelling and deformity later. And the leg is short and lies in flexed, adducted and internally rotated position, and the thigh rests on the another limb, and there is shortening of leg as well, and the head of the femur is felt in the gluteal region, and the mobility is also reduced, and the vascular sign of Narath is also positive. The vascular sign of Narath is positive in the posterior dislocation of hip joint because due to posterior dislocation, the hip joint falls on the femoral artery and this causes feeble or absent femoral pulse, and if there is presence of absent femoral pulse, this is known as vascular sign of Narath, and so, due to the falling of hip joint on the femoral artery, this causes feeble or absent femoral pulse. So, the vascular sign of Narath is positive in posterior dislocation of hip. So, as we have already discussed that in posterior dislocation of hip, the leg is short. The leg is short as compared to the another limb, and the leg lies in flexed, adducted and internally rotated position like this. Okay, internally rotated. The leg is short. The leg is short. It lies in flexed, adducted and internally rotated position. And in posterior dislocation of the hip, the head of the femur lies in the gluteal region due to dislocation. And now talking about the anterior dislocation of the hip, the leg is in abduction and external rotation position. This is abducted and externally rotated, and the head of the femur is in groin area. And in center dislocation, the head of the femur is in rectal area. That is, while doing per rectal examination, we can feel the head of the femur. Now, we have already discussed about the clinical features, and we are going to talk about some special cases. So, as we all know, the posterior dislocation or the dislocation of the hip can be missed very often, especially when it is associated with other more obvious injuries like shaft of the femur. When there is fracture of the shaft of the femur, then there is likely more possibility that the dislocation of the hip can be missed. So, it can also be unnoticed in unconscious patient as well. So, it is very wise to do X-ray of pelvis in all the patients with fracture of shaft of femur. And now let's talk about the radiological features. And in X-ray, in anterior posterior view, we can see that this femoral head is out of the socket and it is above and behind the acetabulum. It is above and behind the acetabulum. This is acetabulum and the head of the femur is above and behind the acetabulum, and there is breakage in the sentence lines as well. There is breakage in the sentence line, and since the thigh is internally rotated, the thigh is internally rotated, there is prominency of greater trochanter. We can see that the greater trochanter is very much prominent. So as we have discussed in the figure that in anterior posterior view there is femoral head out of the socket and above and behind the acetabulum. If there is any associated fracture, we can also see that, and there is breakage in the sentence line. Due to the internal rotation of the thigh, the greater trochanter is highly prominent, and in oblique view the different size of fragments can be seen, and in CT scan we can see the detailed explanation. And now talking about the classification, there is Thompson and Epstein classifications. And in type 1, there are type 1, type 2, type 3, type 4 and type 5. And in type 1, there is dislocation of the head of the femur with no more than chief fracture of posterior acetabular wall. And in type 2, there is dislocation with single large fragment of posterior acetabular wall. And in type 3, there is dislocation with comminuted fragment of posterior acetabular wall. And in type 4, there is dislocation with fracture through acetabular floor. And in type 4, there is dislocation with fracture through acetabular floor and there is fracture in femoral head as well. So these are 5 types of classification. And now talking about the treatment, reduction of a dislocated hip is an emergency. Since longer the head remains out, more the chances of it becoming avascular. In most cases, it is possible to reduce the hip by manipulation under general anesthesia. The chip fracture of the acetabulum, if present, usually falls in place as the head is reduced. And open reduction may be required in cases where closed reduction has failed, usually in those presenting late. And if there is intra-articular loose fragments, it is not allowing accurate reduction. And if the acetabular fragments is very much large and is from the weight-bearing part of the acetabulum, such fragment makes the hip very much unstable. So now let's talk about the technique of closed reduction, that is Ellis technique. Now let's look at this figure. This figure is showing the Ellis technique for reduction of the hip dislocation. So first of all, the patient is anesthetized and placed supine on the floor, and the assistant grabs the pelvis firmly, and the surgeon flexes the hip and knees at right angle. The surgeon flexes the hip and knee at right angle and applies traction in the line of femur, and the surgeon applies traction in the line of femur, that is axial pull. And once the sound of reduction is heard, that is clunk sound, if it is heard, then it is possible, then it is known that the hip has been reduced in its place, and it is possible to move the hip in all directions and the stability is accessed. And then the hip should be kept in light traction with hip abducted for 3 weeks, and then hip mobilization exercises can be initiated. So as we have already discussed that the treatment is based on the type of the dislocation, and for the type 1 there is close reduction under general anesthesia, and we will do that by Ellis technique. And in Ellis technique we have already discussed in the figure that patient is anesthetized and placed supine on the floor, and the assistant grabs the pelvis firmly, and the surgeon flexes the hip and knee at the right angle and applies traction in line of femur, that is axial pull. And once the clunk sound is heard, that is the sound of reduction, then it is possible to move hip in all directions and the stability is accessed. And then the hip is kept in light traction with hip abducted for 3 weeks, and then hip mobilization exercises can be initiated. Now for the type 2 dislocation of the hip, we will do immediate open reduction and internal fixation. And for type 3, we will do closed reduction first, and if there is retained fragments, then we will do open reduction. And now talking about the type 4 and type 5 dislocation, first we are going to do close reduction, and if there is retained fragments or joint incongruity, then we will go for open reduction. So these are the treatment modalities, that is for type 1 we will go for close reduction under general anesthesia, that is Ellis technique. And in type 2 we will do open reduction and internal fixation. In type 3 we will go for close reduction first, and then if retained fragments are present, then we will go for open reduction. And in type 4 and type 5, first close then open. And now talking about the complications, there is early complications and there is late complications. In early complications there is sciatic nerve injury and vascular injuries, whereas in late complications there is avascular necrosis of the femoral head, myositis ossificans, osteoarthritis and recurrent dislocation. Thank you.